And again, you can print that offline. Like literally it's a checkbox.
Mhm.
You can't mess it up. Like you just follow it. And the higher the score, the more severe the withdrawal is.
Well, hey there, it's Liz Rohr from Real World NP, and you are watching the Real World NP YouTube channel. We make weekly episodes to help save you time, frustration, and help you take the best care of your patients. Well, hey there. I have an awesome interview for you. I have Shelby Pope, who's a nurse practitioner with her doctorate. She's both a family nurse practitioner and she has her psych as well, her psych degree, psych mental health nurse practitioner degree. And she's also certified in addiction medicine. And so we had a beautiful conversation about addiction medicine. And I'm really passionate about this topic because and I touch on it a little bit when we get into the interview, but there's so much stigma around addiction and how to support patients who are struggling. There are so many facets of addiction medicine, but what we're talking about in this interview is primarily about opiate use disorder, the treatment options, and specifically buprenorphine. We talk about uh, what kind of the journey that brought Shelby from primary care, family medicine into addiction medicine. And hopefully that journey can be helpful for you as you're thinking about your own journey and your own decision making in your career. And then we also talked about just kind of like what is so special and so important about addiction medicine. And I think that one of the things I really love about the interview and what I love to bring to real world NP as well is just like what is the beauty and magic in medicine, which like sounds kind of funny. Like I've talked about it with my other friends who are not in healthcare, and they're like, "How I hate going to the doctors. I hate going to the clinic. Like, how could that possibly be beautiful and magical?" But it is. And so I think that she really brings that into this conversation of how special it is and how impactful it is and how accessible it actually is. Because I think a lot of times, not only because of the stigma, but also because of clinician discomfort, we're just like, oh, I don't think I could prescribe buprenorphine. I don't think I can manage opiate use disorder. But in our conversation, we really break it down in terms of concretely, like what does it look like, right? Like how do we approach these situations? How do we get more comfort thinking about how to provide addiction medicine in primary care? Really like to the point, very clear. What are the resources to look at? How do we learn more? And yeah, I talk about, like I said, I talk about this a little bit in the episode, but there's so much stigma, but it's a life and death. It's what we're talking about here is life and death. And it's about reducing morbidity and mortality for disease. And we have so much opportunity to be incredibly impactful in primary care. And it doesn't have to be as scary or intimidating as I think a lot of us find, whether or not we're like students or new grads or even experienced providers, or maybe providers that are coming back into primary care or coming to primary care for the first time after being in a specialty. Like this is such an accessible, wonderful thing. And it has definitely me feeling really fired up about how do I do more of this in my practice. So I hope you enjoy our interview. Yeah, without further ado, here is Shelby and my conversation about addiction medicine, specifically opiate use disorder and buprenorphine. I am so excited you're here.
Thank you.
Can you introduce yourself for the people?
Yes, for the people. I am Shelby Pope. I am a nurse practitioner. I have my doctorate, um, family nurse practitioner. I actually just finished my psychiatric mental health NP, the postgraduate certificate as well. And I'm currently certified in addiction medicine as well, or I'm a certified addiction registered nurse advanced practice because
Ooh.
I know it sounds fancy. There's too many letters. We're really bad about that in the nursing profession. We have
Yes.
too many acronyms. Um, and I currently work in an addiction medicine behavioral health setting. It's an outpatient substance use treatment clinic. We provide methadone, Suboxone, like buprenorphine based treatment, and do other substance use treatment. I do also have a background in primary care in rural Oklahoma, and I was actually recruited to work here. And I've been here for almost a year and absolutely love it. It's just been really, really great. Been a nurse for going on 11 years now, which is really hard to believe. But overall, I love what I'm doing and I want to spread the gospel of treating
Yes.
substance use disorders.
I love it. I love it. I have some nosy questions. So did you get your doctorate as in a family nurse practitioner degree first and then went back for mental health? psych mental
Yes.
health?
So,
Cool.
right before COVID hit is when it was about maybe a year and a half before COVID, I decided to go back to grad school and get my FNP because I thought that I just really wanted to do primary care. I grew up really rural. I wanted to stay kind of in the country setting.
Yeah.
Um, and but I didn't personally, just personal preference, I didn't really care for the online platform. And there was a brick and mortar FNP program here in the Tulsa area, but they only offered a doctoral
Oh,
degree.
okay.
It was a master's was not an option, so it was kind of chosen for me.
Yeah.
But I have no regrets. It was great. I feel like it was a really wonderful program, and I feel like I've done good things as far as networking goes, it being local and um, I made a lot of connections. In fact, I just called a peer yesterday that's working in a community health center that I went to school with. So it's
Cool.
great. Yeah,
That's awesome. And, did you get your PhD or DNP?
DNP.
Cool. And then how'd you go back to, get your psych, second degree, second, certification? What kind of led you down that path?
Well, you can probably relate to this. There's a lot of mental health in
Yeah.
primary
Well, I was
care.
gonna say that's why I'm asking because I think like that's been on my mind for it. Like as soon as I got into family medicine, I was like, oh boy, I
Right.
need a second degree now. So
Yes.
yeah,
And
yeah, go
and
ahead.
when you work with your peers, you find that you kind of morph into their prescribing patterns as well. And
Yeah.
I found the providers that I worked with initially, they were so wonderful. They were so great to work with, and they were so supportive. And it was a great learning environment as a new nurse practitioner. But it was their comfort zone was like about this big in terms
Yes.
of mental health. It was
Yeah.
you try one or two SSRIs, maybe an SNRI, and if that doesn't work, they're resistant and you need to send them to psych. And then
Yeah.
they get to wait for 6 months before they get in. Or if we did add an antipsychotic, the best we could do was like 2.5 milligrams of Abilify. Like
Yes.
it was, and now it's like, oh my gosh, I was doing nothing. I was like
Yeah.
not helping at all.
Yeah.
Um, but yeah, so I realized pretty early on, I'm like, I just feel like there's a lot more to offer as far as mental health treatment goes.
Yeah.
But I didn't feel comfortable with just like reading about it. I really felt
Yes.
like I needed more
Yeah.
focused clinical hours in it. And that's what pushed me to do my psych NP is I really wanted the at least 500 hours in clinical settings. And I have no regrets. It was great.
That's fantastic. And then did you bring that degree back with you into primary care or did you go is that when you made the transition to addiction
So
medicine?
I had actually been working on my psych mental health NP while I've been working here. Um, so I actually transferred here as an FNP. So I was working in addiction medicine initially, just as a family nurse practitioner. But I had actually I did like the 24-hour waiver training while I was in primary care. And I was exposed to a lot of substance use disorders in primary care setting initially. And that's what kind of sparked my interest. I'm like, man, we're really not doing
Yeah.
our patients any favors by not being willing to treat all of these issues.
Yeah.
Um, so, and I'm kind of going to go down a rabbit hole here, so I apologize. But when I was in primary care, while I absolutely loved my collaborating physician, um, he was very much against any form of controlled substance. Like
Yeah.
it was very much a hard stop.
Yeah.
And I'm learning the longer I'm in practice, it's just not black and white, right?
Yeah.
Like we can't be
Yeah.
one extreme of the spectrum or
Yeah.
the other. There's definitely a safer middle ground. And I had one particular patient who came in from another primary care setting. She was stable on, I believe it was like 8 milligrams of buprenorphine for opiate use. And doing really well and had been doing well for years and wanted her meds continued. And my collaborating physician said, absolutely not. You have to refer her out to addiction medicine. She needs to go drive into Tulsa, which was like a 40-minute drive. And the wait list for the addiction medicine clinic that he recommended was 6 months. And I'm like, so what
Gosh,
what do we do in
gives
the
me chills.
meantime? I know,
Yeah.
I know, but this
Yeah.
is real world. Like that's
Yeah.
that's that's genuinely what happens, and I
Yes.
see it every single day now. Um, and I'm like, so what does she do in the meantime?
Yeah.
What do we offer?
Yeah.
And um he's like, no, it was a very hard no. So then we got through that. I was able to, because of my connections of doing my DNP in the Tulsa area, I was able to get her in, but not everyone has those connections.
Yes. Yeah.
So I afterwards I was like, you know what? I'm gonna build up some proof, so I did like all this research, like how we should be offering this service, and I did the 24 hours training to show him. And at the time, the X waiver was a thing, and I may have misunderstood the guidelines, but I'm pretty sure your collaborating physician also had to carry the X waiver in the state of Oklahoma, in order for a mid-level provider or nurse practitioner to prescribe with their X waiver. So I did the 24-hour waiver training. I went to him and I was like, did this whole spiel. Like I did, I've done this. I feel really confident that we can offer this service. Would you be willing to pursue the waiver? And he was like, just
Still no.
absolutely not. Absolutely not.
Yeah.
He was and he the kindest person and was
Yeah.
just so wonderful. And I'm not sure where the core of those reservations came from.
Yeah.
Um, but it didn't sit well with me. I had like
Yeah.
such a moral dilemma with it. And it was such a weird thing because I was having like one of those hell weeks, I'm sure like
Yes. Yes.
it happens, right? And I had literally just walked out of a room about a week or two later. I'd walked out of a room with a patient who was screaming at me because I diagnosed them with diabetes. And I was just like so overwhelmed. And my watch was buzzing, so somebody had been calling my phone, and I thought I had a cold call out to a psychiatrist on another patient. I'm
Yes.
putting I'm
Love
putting
it.
I'm putting my cold call plug in because they work.
They do. They're
Do
scary, but
it.
they work.
They're so scary, but after you do it so many times, it's like, oh my gosh, everyone needs to do this.
Yes.
It works, and
100%.
it really benefits patients so much, and you make so many connections so that when
Yes.
you need connections, you have them.
Yes.
Um, so I had this call coming in, and I run to my office and answer it expecting it to be the psychiatrist, and it ended up being my current clinical manager. And he was like, "Hey, I know this is really weird. I was a part of the HRSA loan repayment program." And he's like, "But I saw your name on the list, and we're currently looking for a nurse practitioner to replace our current provider. And I was just wondering if you'd be interested in working in addiction medicine. I know it's kind of a stigmatized field." And I was like, "Universe? Are
Oh
you
my
talking
gosh,
to
it
me?"
gives me so many chills.
I
I
know.
love that.
I
I love
know.
that.
And I was like, this might be weird, but yes, I am interested. When would you like me to interview? And he's like, can you be here Friday? And this was like literally a Thursday. And I'm like, absolutely, I'll fax you my resume. Like,
I love that.
yeah. And then got offered the position, and I've been here since, and we're doing great things. I love it. It's good work.
I love that. And thank you so much for telling that story because I think what's really helpful for people to hear about is that like there are just so many different routes to get to the place that we want to go. Because I think sometimes that we go into primary care or becoming a nurse practitioner thinking it's going to be one thing, and then we just like can let our path evolve as it goes, right? Like
Right.
I imagine you didn't see yourself starting here when you were in grad school. Maybe you didn't see yourself getting a psych degree, like so.
No.
There's so many different options, and like you are just, I mean, before we got on this recording, when we talked before, like you just light up talking about addiction medicine, right? Like
Oh,
it's
thank you.
so special, and
Yeah.
it's so nice to share with people. It's like this is an option, which kind of brings me into my next question about like I think that what thinking about this episode, I'm thinking about the people who are in school, the people who are new grads, and the people who are coming to primary care for the first time after being in a specialty. Like, if we're like, I think that there's this because, like you said, there's stigma in this field, and some people are like, oh, addiction medicine, like
Mhm.
that physician. I don't know anything about your collaborating provider, but I've heard a lot of people that they kind of just have this hard stop because of discomfort.
Mhm.
And so I would love to hear from you, like, what is it that you love about addiction medicine that like lights you up that can help be an entry? I think it will be a real entry point for people to like be like, oh, this is possible and it is cool and it is exciting. Like, what are the things you love about addiction medicine?
I can literally feel the tears coming, so I'm gonna try to hold it in. I'm so
Tears are
sorry.
welcome.
I'm
All the
such an
tears.
emotional person. It's so embarrassing. Um, when I tell you, so again, I've been a nurse for almost 11 years, and I've done some really gratifying work. But it doesn't even compare. It doesn't hold a light to this. Like, um, on a daily basis, I see people walk through the door and pull themselves out from the depths of hell. Like,
Wow.
absolutely the most horrific stories. And I see a lot of in terms of the spectrum, one extreme or the other. Like I see the generational substance use, the generational poverty, and the individuals that genuinely just like, I want to break the cycle. I
Yeah.
recognize that this is a cycle and I want to do better. Whether it be they're self-referred or they're court ordered, um, they do recognize it and they want to do better and they're trying. And then I see the people the other people, with strong
Yeah.
quotations, the
Yeah.
other people that are, again, strong quotations, just like you and I,
Yeah.
who had one significant injury,
Yeah.
one car wreck, one surgery, one gallbladder that a cholecystectomy that went bad and had to have multiple, um, had to have a wound vac and all these things, and were on pain management for, a couple of months, and it spiraled out of control after being prescribed opioids by a provider appropriately.
Yeah.
Um, and then I also see a lot currently with how the guidelines changed as far as prescribing goes, which I could go. It's another rabbit hole. I'm gonna try to hold it back. I'm gonna try to hold it back. Where people are just cut off from pain management.
Yeah.
And then they're sent here because they have nowhere to go. And I have many patients that resorted to using fentanyl on the street. Um,
Oh,
so
because
I,
they were on pain medication and
because
then
they
they
were
were
on pain
discontinued. I
yes, because they
understand.
were on pain meds, and for one reason or another, because of really unrealistic expectations, or because someone has drawn this like line in the sand of I will not prescribe over this, but their pain's not controlled. Like, we're
Yeah.
not treating the patient, we're treating the algorithm.
Yes.
Um, and they start supplementing, because who wouldn't,
Yeah.
like, I'm
Yeah.
hurting, this isn't
Yeah.
working anymore. Or they were on a regimen, and my collaborating physician saw one of my patients yesterday because he has one of those like heartbreaking cases. Was in pain management, was kicked to the curb because after the guidelines changed, he was cut way down on his prescription. Had been well managed before that, had no reported history of misuse, and then he got kicked to the curb, and he's like, he could barely walk. I mean, he's honestly to the point of like has very poor quality of life, and you can visualize his discomfort in the visit, and it's so provoking. Like, it's so hard to watch. And my collaborating physician currently is both board certified in pain management and addiction
Oh,
medicine.
beautiful.
So it's wonderful.
Yeah.
And he saw him, and he was just like, I'm so mad. I'm so mad. Because he got kicked to the curb, he started supplementing with poppy tea. And then because of that, with that termination, he ended up here. And he's like, what do I do? And then I'm supposed to prescribe him Suboxone, which really, at the doses we do, does not really help with his pain. So it's tough. So as far as like the work, and being gratifying, it really, on most days, it really restores my faith in humanity, of like knowing that these people need help, they are appreciative of the help. Um, and it's just, oh gosh, I almost wish I could just like wear a GoPro and like just release the footage. Obviously
Yeah.
it's a huge HIPAA violation, I would not do that. But
Totally. Totally.
I think, and if you would have told me 5 years ago that I would have ended up here, I would have been like, you're out of your
You're like,
mind.
no way. Absolutely
No,
not.
I never would have thought I would have done something behavioral health wise, because I think we see it, some of us see it through a lens of, our history. So I used to work acute care, and the patients that I would see in the hospital setting were a lot of times with active substance use, were homeless. They had like active psychosis due to like either alcohol withdrawal or schizophrenia. And so I saw all these extremes, and I'm like, oh my gosh, like if that's what it's like to treat these people and
Yeah.
that's all I would ever see, like, no,
Yeah.
I don't want to touch that with a 10-foot pole.
Yeah.
Um, but that's not a majority of the cases. Like,
Yeah.
those do come up, but those, for a vast, vast majority of my patient population, they're wonderful individuals that just want help. They just
Yeah.
want help.
Yeah. And so I'd love to, there are so many different pieces of addiction medicine, but coming onto this call, we talked about kind of going over buprenorphine, Suboxone, and like I feel like it's one of those things that there are certain topics in primary care that it's like people treat it as like, oh, no, no, it has to be a specialist, like
Hmm.
HIV care or certain like gynecological things. Like I feel like this is an opportunity. I think depending on your practice setting and the supports that you have, it's important to bring this, like start thinking about bringing this in. Like if they're like, maybe if we can start with that, like how I guess when before I was thinking about like what are some of the things that like somebody who's like, I'm here, I'm hearing this, I want to do better with addiction medicine. I want to think about how to support patients like this who are going through this. Like, Can we talk about like that process of how you see it happen in primary care or how you can envision it happening in primary care? Like
Yes.
how it's like what is the and you talked a bit about X license. So actually, I don't know if you said X license, but I heard X license. But do you want to
Yes,
talk
I did.
about yeah, do you want to talk about X license before we jump into that?
Yes, so that was removed by the Biden administration. I think it was in 2022 they removed
Mhm.
it. So you do
Like
not.
what an X license is for people who aren't
Oh yeah,
familiar.
so there
Yeah.
was like an X waiver that was added to your DEA number that showed that you were capable and competent to prescribe buprenorphine to individuals with opiate use disorder. Um, the um, caveat to that was there was also a limitation on the number of patients that you could treat.
Yeah.
And I don't even remember what those were, but I think it was
Yeah.
like initially for like the first year it was a limited amount, and then you could apply to increase it to like 250 patients in the second year. And then, eventually they did realize, this is a huge barrier to treatment,
Yeah.
because listen, I work primary care. I know what that's like. I
Yeah.
know in terms of how busy it can be. The last thing we want to do is like do another like 24 hours of training in anything.
Yeah.
But now that it's actually I think it's everywhere. Correct me if I'm wrong if you know. We have to have 8 hours of opiate use training um, to continue licensing, and I think that has to do with our DEA number. In the
Yeah.
state of Oklahoma, I know it's required, but I don't know if it's everywhere.
Yeah.
Um, so there so those classes that were actually required initially for the X waiver, there was like an 8 hour and then a 16-hour training. Both of those are free online and they still qualify for the DEA requirement. Um, as far as so that did that answer the question as far as what the
Yeah,
X
just to
waiver
kind of
was?
apprise people. And I'm not familiar with like the national different rules about like how people would be getting into this. So but I can always like put that in the show notes afterwards. So
Okay,
yeah, go
okay.
ahead.
Um,
But we don't have that anymore. So people could,
yes, so
yeah.
so X waiver was removed.
Hmm.
So anyone with a license to prescribe, depending on what your state's regulations are, obviously anyone would have to do their
Yeah.
own due diligence with
Yeah.
that, can prescribe buprenorphine because it's a very safe and effective medication.
Yeah.
Um, but unfortunately, I think the most recent article that I read, it said buprenorphine prescribing actually plateaued
Yeah.
between 21 and 22. Like, so they removed this barrier. I think it is beginning to like slightly creep up,
Yeah.
but they removed the barrier and it just like kind of went, buh.
Yeah.
There wasn't like a
Yeah.
rush in the field to like start prescribing this.
Yeah.
But I will give the nurse practitioners a little plug because I was on a journal club out of Maryland last like 2 weeks ago, and there was a physician on there that practices in addiction medicine, and he's doing a study currently on the prescribing patterns of buprenorphine, and he said that nurse practitioners are the most rapid uh,
Nice.
profession prescribing buprenorphine, and so he applauded us for that.
Wonderful.
And I could go down a whole nother rabbit hole with that, but I won't.
Well, that's wonderful. So I think that I want to start by saying a disclaimer of like, if anybody is especially who's listening is like, a brand new grad, or even if you're an experienced provider, it's important to get support, especially when you're kind of coming up with like a program. Because at least my experience in the clinic that I was in before, there was a medication assisted treatment program. And so
Hmm.
we kind of had like all these different protocols set up. We had a nurse that worked with patients. We had like it was more than just like me in a visit prescribing something. So I actually haven't prescribed Suboxone before, buprenorphine, but that was the container that we had before. So I just want to give that disclaimer that it's not necessarily just like run out and start prescribing like
Right.
tomorrow. But I want to paint a picture for people so that it's less scary, so that they can feel comfortable taking those next steps forward. And I'll share some stuff in the show notes about like, what are some of the steps that they can do and like organizations they can look to and the education, like the regulatory stuff. But if we put that aside for a second, I just want to talk about like the process of Suboxone, like, excuse me, buprenorphine. So, how do you, when you're, say, if we put ourselves in like a primary care and I want to do this for somebody, how do I know if somebody's ready? Like, if I have somebody who's like, I really want to start this, like, what are the first steps? Like, how do I know that this person is ready? And like, what are those first steps of like, what do we need to assess there? What is the shared decision-making conversation? Like, what are those kind of initial things in that first stage? Yeah, where would you advise somebody to start in that, or what does
So
it look like?
I think, okay, so first and foremost, I would start. I want to mention like in terms of acuity with individuals, like if someone is already stable on any form of buprenorphine and
Yeah,
doing well and have been on that dose for many years, I highly encourage any provider to continue the medication for them and
yeah,
allow access to it.
yeah,
As far as the guidelines go, there's no hard and fast as far as required drug screens, whether they have to be observed, unobserved. Obviously, that needs to go along with people's clinical judgment. The guidelines do recommend at least 6 to 7 drug screens per year. I typically see patients monthly that are stable. But depending on state guidelines and restrictions, you could prescribe this medication for 90 days without a visit. We have a restriction in the state of Oklahoma. I can only send in up to 30 days of medication.
hmm
But I could like put a calendar reminder, to send it another one if people were stable enough. But um, I like checking in with them monthly personally,
yeah,
specifically in our patient population, because things come up and there's a lot of stressors, there's a lot of barriers to care for these people. So, um, I see them monthly. A drug screen. Our clinic specifically does require observed drug screens because we also dispense methadone. There's a lot of controversy on that. I don't, and I'll be just very blunt about it. I don't agree with forcing everyone to do observed drug screens. I think it's really intrusive, and specifically for individuals with history of trauma, which a vast majority of my patient population has
yeah,
some form of sexual trauma. Um, and also, it's just like a mistrust thing. Like,
hmm
obviously, there's going to be individuals that will falsify a drug screen. It happens,
yeah,
and I've had it happen. But when you sit down across from the human and you have a conversation with them,
totally.
9 times out of 10, they're just like, I'm so scared that you weren't going to give me my buprenorphine because I'm on meth. And I'm like,
Yeah,
those are two separate things,
yeah,
friend. Like, it's
yeah,
okay. Like, we'll
yeah,
continue the bupe. That's fine.
totally.
But I need you to not do that.
Lie to
Okay.
me.
Like, I
Yeah.
need you to be honest
Yes,
and transparent because I don't know how to help, if you don't.
totally.
Um,
Totally.
so mainly, so continuing it if they're stable. As far as knowing when someone's ready, first, like this is the core of being a nurse, right? Like
Yeah.
have the conversation
Yeah.
and ask. Um, mainly and in primary care, it wasn't like a huge percentage of patients that came in and they were just like open about their substance use. A lot of time, and I'm kind of going to go off track for just a second, like specifically with alcohol, like that one wasn't talked about a lot, but
Yeah.
their blood pressure would be through the roof, they're
Yeah.
tachycardic, they're diaphoretic in the office, and you're like, something doesn't look right here.
Yeah.
But they're not open about it. So screening, obviously, like you
Yeah.
need to be having a conversation on a regular basis with your patients about, hey, any illicit substance use, and obviously initially on the first visit, like substance use, tell me about that. And it's amazing when you have the conversation and you open the platform and you make them not feel intimidated or
Yeah.
rushed, which I know is complex and difficult in
Yeah.
primary care. I know
Yeah.
um, that they are open to talking about it. And I have had patients come in, and a vast majority of my opiate use patients um, they desire to get off fentanyl. It's a
Yeah.
nightmare. It's a dirty, dirty drug.
Yeah.
Oh, I hate it.
Yeah.
I've had so many addiction medicine like mentors tell me that they hope for the days of heroin again because
Yeah.
fentanyl is just such a high up, low, low, and it's constantly like that. And a lot of patients really don't like it. They're just
Yeah.
like,
They
the
don't.
withdrawal is terrible.
Yeah.
Um, and the potency of it, as far as how it binds to the receptor, is very intense. So the withdrawal is very intense. Far worse
Yeah.
than people like I have people that, historically used heroin, couldn't find it anymore, and started fentanyl. And they're like, this withdrawal is on a different level, and I don't want to do it anymore. I'm tired of this game. Um,
Yeah.
so opening the platform, allowing people to tell you when they're ready. And then as far as starting it, fentanyl, starting buprenorphine, there's different treatment options, and I want to kind of talk about that for a second.
Yeah.
There's 3 options specifically for opiate use disorder. There's naltrexone, which is to be honest, as far as the new data, a little bit controversial because there's some data I think there needs to be more time in terms of research on this, but there's some data that shows that there may actually be an increased risk of overdose and death with
Yeah.
naltrexone, because it has a high potency, or high affliction for the receptor as well. So you would, and I always educate patients on this, they would have to take an astronomical amount of opioids to like push that off the receptor.
Yeah.
Um, and it vastly increases their risk of overdose and death. So
And so
education,
that,
obviously.
and then just to pause, so just
Yeah.
thinking about the newer people. So, oh, with naltrexone, this is an opiate blocker,
Yes.
basically, and it's
Yep.
100%.
Yes.
Like it's a
It's
complete
an
blocker.
antagonist.
Yeah.
It's an opioid antagonist. So
Yeah.
it completely blocks the receptor so that if an individual were to relapse, like have one slip up, it would
Yeah.
block the receptor enough where they would not have, a positive association with use. And it also decreases opioid cravings. It's also used for alcohol, so it decreases alcohol. So if you have somebody with multiple substance use issues, there's also some data that shows that it may be beneficial as well for methamphetamine use,
Mm.
specifically the injectable form Vivitrol, the injectable naltrexone that people would do once a month. That's probably getting a little bit in the trenches in terms of addiction medicine.
It's
And
nice to
really,
know it's nice to share what the options are though, because I think that
yeah,
at least for me in primary care, it was like those were the two things when people came in with opiate use disorder. It would be, are we talking about naltrexone, like a total cessation where we're gonna do that? And it's like a daily thing until you get to that injectable, and then it's an injectable for a month. And then that's kind of that nice support for those people because then they don't have to be dependent on themselves to take a medicine every day to prevent their cravings and their use.
right.
Versus a buprenorphine, which is we'll talk a little bit more about. But yeah, no, I think it's good to bring on naltrexone.
I think the most important thing to talk about in terms of naltrexone, if that's something that's on the table of consideration,
Yeah,
is that it will precipitate withdrawal if you give it to your patient that's actively using opioids. So if somebody comes in and they're like, "Hey, I used fentanyl a couple days ago. I heard about this shot. I want to do
yeah,
it."
yeah,
The answer would be no.
yeah. That day, not
Yeah,
today, not right
not
now.
today. We can work on it.
Yeah,
But they need to really have opioids out of their system entirely. I would honestly recommend a urine drug screen that shows no opioids at all. Um, and then if you're doing unobserved drug screens, you really need to educate the patient, hey, if you've used opioids at all
yeah,
and you've been using them and I give you this, and you always do a trial for a few days of the oral naltrexone. Some say up to 2 weeks, but
yeah,
honestly, you could do 3 or 4 days
yeah,
before you start it. If you can get it approved through insurance, that's always the caveat. Um, but you have to, really educate them like this can make you really sick if you, and most patients don't want to be in withdrawal. So they'll be
yeah,
transparent, like, oh, I'll be
yeah.
honest, doc, like
It was
this
a
isn't
little
a good
sooner
idea.
than a couple days ago. It's kind of
Yeah.
yesterday.
Yeah.
Oh,
Okay. If,
yeah.
oh, I'm gonna go, I'll take that back. Yeah.
Yeah. One of the
Uh,
nurses that I worked with used to counsel patients that it's like you won't die, but you will kind of be
Wish you
in
were
so
dead.
much discomfort. Yeah, you would wish you were dead.
Yeah.
So
And
like
it's true.
that's a very
It's
blunt
true.
way to put it, but
Hmm.
it's accurate. So yeah, so that starting of that naltrexone process is a little bit different than that sounds like the buprenorphine process, which could be somebody's coming in and wanting to continue what they already have, or somebody that's like brand new and they're like,
Hmm.
I have opiate use disorder. I'm using, like as you said, like it kind of like just to set the scene for people, it sounds like when somebody comes in, you're getting a history with very non-judgmentally of like, let's just talk about all the options and
Hmm.
there's nothing wrong here. Just tell me all the things, how often you use, what are the things that you use, when was the last time you used it? Um, and like, yeah, just I guess gathering that history piece of like what they're looking to do. And it's like, you know what, I'm taking fentanyl and I just don't want to do this anymore.
Hmm.
And so you have that conversation with them or the provider PCP does, is it an naltrexone? Is it buprenorphine? It sounds like those are the two main ones that you're really going to think
Hmm.
about in primary care versus methadone is kind of, we're not going to really talk about methadone today, but that's another
Right.
potential option. But
Which I do, I would like to make a plug for methadone here just
yeah.
because with the fentanyl era and how potent it is, and now carfentanil, I don't know if you've heard about that,
Mm-mm.
is on the market, and there's a whole other one that's even being added. So carfentanil is actually 100 times more potent than fentanyl. And I just had a patient today, actually a new patient that first thing this morning that said that he knew for a fact he was using carfentanil. And I don't know if that's something that the dealer was saying because like, ooh, I've got a really potent
Yeah.
stash,
Yeah.
which happens. But
Yeah.
so I've had, obviously had people talk about it. And with that, we are finding that some of our patients just the potency and extreme nature of fentanyl, many of them do require methadone treatment. I
See.
always recommend, first and foremost, trying buprenorphine and seeing if we can do an induction and get them on it, and get them stabilized and comfortable. And if not, in an outpatient setting, get them to go to detox and try to go that route. And if those things fail, methadone is always there. But I'm in a setting where I can offer methadone today, like, so
Yeah.
if I have somebody coming in and they're like, I can't do the withdrawal. I can tell you right now, I cannot go more than 1 day without using fentanyl. I cannot tolerate it. I'll be like, okay, we've got methadone. That's okay. We can get you on something.
Yeah.
And as far as statistics go, I actually like made it myself a note so that I wouldn't forget to mention it, just so people like really understand. So, according to the National Institute of Drug Abuse, patients using methadone and buprenorphine are 60% and 40% less likely to die of an opioid overdose. So,
Yeah.
60% if they're using methadone, 40% if they're using buprenorphine. So,
Yeah.
it vastly, vastly decreases risk. And
Yeah, which I love to just highlight there that like if anybody like thinking or like who's listening is thinking about like they're still intimidated, they're like not really sure. And we talked about this before recording, but it's like the this is life saving.
it
Like that's
is,
the bottom line moral of the story here is that there's a lot of stigma, there's a lot of I think education and discomfort and gaps that we need to address for primary care providers, but the bottom line is that if we're talking about reducing mortality, this is reducing mortality and we wouldn't I think it's interesting to think about because it's like if we're talking about mortality reduction in this field, if we're thinking about diabetes, doing something that reduced mortality by that percentage, like there would be no questions here. So I just
absolutely.
want to be on that little pedestal for a second. So
I appreciate the soapbox because
yeah,
it's so important. Like, I think the statistics say now that only 1 in 5 individuals with opiate use disorder have access to medication.
yeah,
So that means
wow,
80% of individuals are going without treatment. And this, I mean, I think that the statistics are 80,000 people are dying yearly from opiate overdose.
yeah,
80,000. I
it's a
mean,
lot of people.
it's so much. And
Yeah,
and by and large, all of the data is very conclusive in the fact that if you allow access to medication, it reduces morbidity and mortality. And medication alone decreases the risk of HIV, hepatitis C, endocarditis. And if you're going to take the lens off the patient, which I never recommend doing, but if you're going to take and just look at the taxpayer burden and the
yeah,
overall cost to society, those three things alone, if we
yeah,
decrease that, it's a no-brainer,
yeah,
right? Like,
yeah.
there's so many things that this medication helps with. So, as far as the induction, kind of gonna backtrack a little bit.
Sure,
Induction
sure.
on buprenorphine. So, first and foremost, obviously having the conversation. And then the first question I always ask is, when was the last time you used fentanyl?
Yeah.
And I say fentanyl because that's really what most people are going to see. Um, there's one extreme or the other. And in my 1 year here, I have seen one person that tested positive for heroin. That's
Mhm.
how it's just not something. And the
Wow.
people in Maryland that I do that journal club with, they said that they haven't seen anyone using heroin, and they work in an addiction medicine setting, so that's all they see. They haven't seen any heroin in years.
Wow.
So
So it
it's
really is.
primarily
Yeah.
it very much is just saturated with fentanyl. Um, and so with that, there's that, and then there's also, I do occasionally get an individual that still has access to like prescription pain pills,
Yeah.
and those two inductions look differently. So if
Okay.
somebody if somebody's coming in using prescription pain pills, the window of time that they need to be abstinent is going to be a little bit shorter.
Okay.
So, and you can literally Google, like, you can find a guideline to follow for buprenorphine induction. It's like super, and
Hmm.
actually I printed one to like show
Yes.
like how easy it is to find
Cool.
one online. The one thing I will say is the one that I found online, it says that you should wait 12 hours before you induce somebody on buprenorphine if they're using fentanyl, and that is incorrect.
Okay.
You really, anecdotally, I find that you really, really, really should have somebody at least 48 hours, if not 72. And if they can push to that fourth day without using fentanyl, that's the best place to start them on buprenorphine. Um, because if you don't, if they start it too early, the concern would be precipitated withdrawal and making them more sick.
Mm.
Than when they started. But if you that the key is educating. I tell people all the time, and I just get really real with them. I'm like,
Yeah.
if you start this too early, if you walk out of my clinic and you pop this in your mouth, you're going to be in precipitated withdrawal. And I personally recommend at-home induction. Some people prefer doing it in the office, but the
Yeah.
data supports that people are more comfortable doing it in their own homes, in their own environments, and it's safe to do that.
Yeah.
So why not make them more comfortable? But if you're not comfortable with doing it and you want to keep eyes on people, I don't care how you do it, just do it. Like,
Yeah.
give them access to meds, please.
Totally.
So as far as induction goes, for pain pills, really almost any form of it, 12, 24 hours. And there needs to, what I recommend going off of is the clinical opioid withdrawal scale. COWS is what we call it. And there needs to be like a score of 12 or higher on that. And what opioid withdrawal looks like is, I call it leaky face. So
Okay.
running,
I love that.
it's easy to remember. And I actually had a patient tell me that one time. She was like, "Oh yeah, I got that leaky face." And I'm like, "Ooh, that's good. That's good. I'm going to use that." Because people know. I'm like, "Oh, you got leaky face?" They're like, "Yes. Yes, I do."
Okay, tell me
Um,
more about leaky face.
okay. So runny nose, rhinorrhea, lacrimation, so eyes watering a ton, sneezing like over and over again. They'll have tons of yawning. People will feel like this intense urge to stretch, and they're like really restless. They're just moving. They're like, I can't, like coming out of my skin. Most people will be diaphoretic. A lot of them feel flu-like they're
Like
very
body
irritable,
aches.
body aches,
Yeah.
chills. Insomnia. Those are all the most common symptoms. Typically with fentanyl, what I'm finding, and this is just an anecdotal thing for me, what I'm finding with my patients that are actively using fentanyl, once the GI symptoms, and everyone's different, so this isn't a hard and fast, but once the GI symptoms start, like if they're having nausea and they're having diarrhea, typically they do well on induction. They can go ahead and start the buprenorphine and feel okay. But still go off of the cows of 12 or higher. And again, you can print that offline. Like literally it's a checkbox.
Mm.
You can't mess it up. Like you just follow it. And the higher the score, the more severe the withdrawal is. And so the data shows at least 12, they should be okay. But there is some data coming out that says people that are using fentanyl probably need a higher score in order to not precipitate withdrawal. So fentanyl's
Oh,
kind
I
of
understand. So if they have those symptoms and they the more symptoms they have, the higher the cow's score. And like, but if it's lower than that, it might precipitate withdrawal. Is that what you're
yes,
saying? Okay.
yes.
Okay.
So if somebody comes in and they just have a runny nose and you're like, oh, well, that's a withdrawal symptom. Let me start buprenorphine.
I understand.
You're
Yeah.
going to push them into withdrawal and make them more sick and make them
Uh-huh.
very uncomfortable because you're pushing the opioid because buprenorphine has a high affliction for the opioid mu receptor. And arguably more so than fentanyl. So if you take the buprenorphine, you're pushing the fentanyl off the receptor and you're putting them in withdrawal. And they will not like you very much
Yeah.
if you do that.
Yeah.
So, and they will typically self-treat. They'll go out and that puts them at risk, you know.
For
They'll go out,
overdose.
yeah,
Yeah.
and they'll go out and use fentanyl. So that's why, and I tell them that in the conversation. I'm like, and if you're going to do a home induction, you really, really, really have to ensure that you're sick, and you have to be sick to the point that you can't stand it anymore. And everyone's threshold is different, but I show them on my piece of paper. These are the signs and symptoms of withdrawal. You need to have as many of those as you can stand, and
Wow.
that's more than two or three. Like you
Yeah.
need to really, really be uncomfortable.
Yeah.
And honestly, the for the year that I've been here, I've really only had maybe a handful of failed inductions,
What
where
do you mean by failed injection? Yeah. What does that
where
mean?
yeah, so with that specifically, they just could not get uncomfortable enough to start the buprenorphine. They
I
just like could not.
understand. So
And then
they would use. Okay.
yes, they would just use. Or I think I've had one patient that used the buprenorphine too early and said that they got precipitated withdrawal from it. But I was actually just listening to a podcast the other day, and I think a lot of providers are gun shy with the buprenorphine because due to fear of precipitated
Yep.
withdrawal. But I just listened to an addiction medicine doc that said, you know, I think there's far more like mistreated patients as far as dosing goes, like not actually giving them access to enough medication rather than actually causing this much precipitated withdrawal.
Yeah.
Because she was like, she's treated thousands of people. She's up,
Yeah.
you know, in the Northeast, and she's like, I've treated thousands upon thousands of patients with buprenorphine, and I see far less precipitated withdrawal than people talk about.
Yeah.
So it's really not that common to cause it. And if you provide appropriate education, it'll be fine. Like,
Yeah.
and if they don't, and my patients that didn't do well on the induction, I just encourage them. Like, obviously, I gave them access to Narcan. Um, Sent them home with it, and I was just like, if this doesn't work out, that's okay. Come right back and see me. You won't be in trouble. I
Yeah.
won't ground you from medication. It's
Yeah.
fine. Like, come
Yeah.
on back. And then we start
Yeah.
them on methadone.
Yeah.
Or I give them the option, of getting them access to case management and helping them get into a detox center so that they can do it in a controlled environment where they have access to medications to support their symptoms. Um, and to make them more comfortable with withdrawal, you can absolutely prescribe like clonidine zero point 0.1 twice a day as needed for anxiety. That really helps patients cut the edge off. Um, I sometimes will give a little baby dose of trazodone to help them sleep because a lot of people complain of the insomnia. You can tell them to take Imodium for um, diarrhea. Um, I mean, there's a lot of supportive things that you can do to help make them comfortable.
Cool.
And these things really do work.
That's wonderful. And so I guess just to recap for people, so like if somebody's coming in, um, is using opiates, typically
Yep.
it sounds like fentanyl.
Yes.
We're doing an assessment of how long they've used it for, how often they're using it. Like I guess the route, we didn't really touch on that, is like they're injecting or other
Yes.
routes. And then when did they last use? Do you ever ask about like the amounts that they use, or is it really just a
Yes.
frequency?
I do. I personally ask because I don't know that it would be super important to nail that down in a primary
Yeah.
care setting. I know how limited the time is. I do it here just because, like, yeah, a couple days ago, I had a new patient who said that he was using 50 fentanyl tabs per day, which that's a lot.
Yeah.
That's a lot of fentanyl.
Do most
So
people
then,
talk about tablets, how many tabs they use?
yes, it's
Hmm.
usually they call it like there's all sorts of names. Some people
Yeah,
call them blues, and I think it depends on what region of the country you're in.
totally.
Some people just call it Fin. I mean, there's all sorts of names, but it's usually in a format of tablets or powder.
Yeah,
Um, I have a lot of people that smoke the powder,
yeah,
and they will usually tell me in grams. Like I do a quarter gram, I do a half gram, I do a gram. And, obviously the higher amount, I know it's going to be a little bit more of a ride to get them on buprenorphine.
yeah.
And the ones that are on higher amounts, I start, I kind of open the platform of methadone too. I'm just like,
Yeah. Well, I guess that's what I'm thinking about in primary care. It's like when somebody's doing an assessment, they're trying to figure out like what is their use pattern and like um, how long they could go before they could not use, because
mhm,
those are the determining factors. It sounds like of like they have to not use for as many days as possible to get to that COWS score. So usually about 4 days, I think is what you said,
mhm,
72 hours to up to four
yeah,
days, or 4 days plus. But if they can't do that and they use every single day, then it's the decision making of do they need detox or do they need, I don't know. I don't know where the status of primary care is on methadone, but it sounds like if somebody, the higher the use that they have, the more likely they're going to need methadone. So they
mhm,
can go from naltrexone is like step one, buprenorphine is kind of in the middle, and then methadone is the higher amount if they have more use or they cannot wait for the
right,
withdrawals,
mhm,
or they go to a detox. So it sounds like that's
yes.
kind of the triage approach for the starting. And then we didn't, I meant to clarify at the beginning, but the word induction just means the first time that you're starting it.
Yes,
So
and what that even looks like, so it varies, but typically I'm gonna just do the very standard induction if that's okay. If I know
yeah, go for it.
before we were on camera previously when we talked, I don't want to be super specific as far as dosing, but there's a pretty much a standard as far as this realm goes. Um, with fentanyl, we are noticing it requires higher doses to be comfortable. So, like
Yeah.
in the Northeast, like it's pretty much across the board that insurance approves 3 tabs a day, which would be 3 tabs of the 8 milligram buprenorphine, which would be 24 milligrams of buprenorphine daily.
Hmm.
Statistically, patients are typically comfortable between 8 to 24 milligrams. Oklahoma, unfortunately, is not very progressive, so
Uh-huh.
insurance only really covers 2 tabs a day. So that's usually what I start with my fentanyl, my people that are using fentanyl. Um, and how induction looks is okay. So you say that withdrawal is moderate to severe. You got at least that score of 12 on the cows. You're really uncomfortable. I'm going to send you home with just a couple days of buprenorphine because we're going to do a really close follow up because I want to see you back in office and ensure you're doing okay. And when you're at home, you're that uncomfortable. What you're going to do is split one of those tablets in half. You're not going to take the full amount. You're only going to take 4 milligrams. And that's also to prevent worsened precipitated withdrawal. So this keeps the person even more safe.
Yeah.
Um, you take that And then the way that this medication is absorbed, and I'm going to do a little sidebar for just a second to
Yeah.
describe the difference between buprenorphine and buprenorphine naloxone, because
Yeah.
there's a lot of misconceptions with that, even with patients specifically. So buprenorphine, plain buprenorphine is just buprenorphine, obviously. Buprenorphine naloxone is the most common, like that's when people say Suboxone, that's what it is. It has that
Uh,
naloxone component. So
yes.
it has the buprenorphine, which is the partial opioid agonist, and then it has the opioid antagonist with it. The bioavailability of the naloxone sublingually is very minimal, but buprenorphine absorbs sublingually. It has a high bioavailability. So for anyone that's not aware, these patients have to dissolve the medication under their tongue or like between their lip. Um, and the buccal membrane in order for them to get the high bioavailability. Because I've had patients that have been on buprenorphine and they're swallowing it and they're like, it's not working. And I'm like, well, you're not taking it correctly.
Yeah.
The naloxone is actually there when it was originally designed. It's there to protect patients that want to divert this medication and use it IV. So it
Mm.
would prevent them from overdosing and dying. That's how it gets like activated ultimately. Like if they're shooting up Suboxone, it won't really work. They're not going to get high from the buprenorphine, and that's a whole other conversation I could have. But so that's the difference between the two. Anecdotally, what I find is patients sometimes experience like headaches or nausea with the combination. In those patients, we kind of have to trial like just doing buprenorphine, but I always try to start with buprenorphine naloxone component because that's what's FDA recommended, and it decreases diversion. So that's where I would recommend starting. So back to starting the med. Split it in half, take 4 milligrams sublingually, see how you feel after about 45 minutes. If you don't feel worse, you're not precipitating withdrawal, so you'll be okay. You can take the other
Beautiful.
half. Yep, just pop the other half in, wait about 4 to 6 hours. If you're still having withdrawal symptoms, go ahead and take the other full tab. So I start with a half, full tab. On day 2, take 2. It's that simple. And then
Cool.
come back in a couple of days, see how you're feeling.
Cool.
And then depending on, there's some controversy about whether or not you should increase dosing based on opioid cravings. Opioid cravings do equal increased risk of relapse.
Yeah.
So for individuals, I will titrate up on the buprenorphine to up to 24 milligrams if they're continuing to have opioid cravings without withdrawal symptoms. There's controversy with that. Everyone has a different comfort level. But for me, I know medication equals less mortality. And if your cravings are putting you at risk for relapse, I'm willing to put you on 24 milligrams because I'm hoping that will keep you more safe. So yeah, I probably said way too much in that,
I think
Liz.
that's
I'm so
great.
sorry.
No, 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 that's totally great because I think that kind of brings us to the next piece of like I'm just trying to like build the picture for people who haven't been in this setting before and working through. So that induction I think is the way you described it is just really clear. I can hear a question of what if somebody is precipitated in is well
In
what if
precipitated
somebody
withdrawal.
yeah, what if somebody is in precipitated withdrawal? Then what has that
Ugh.
happened to you or
I
what do you
haven't actually seen it in clinical practice. And I was actually just listening to a podcast the other day about precipitated withdrawal, and there's some data that shows like, and this is kind of going down a rabbit hole, like microdosing buprenorphine, which it's not really, I haven't seen it done in an outpatient setting. It's
yeah,
usually in an inpatient setting. Um, Mostly though, and I hope somebody chimes in and like corrects me on this, but for precipitated withdrawal, I think most patients will self-treat.
yeah,
They'll go and they'll use to fix the withdrawal that they're in,
yeah,
or they can try to. What I recommend doing is like if it does happen, try your absolute best to ride it out and give it a couple of hours, and then try a very small amount of the buprenorphine again. Do another half tab, like a quarter tab, half
yeah,
of a half, and see if that will help cut the edge off. And obviously doing all the supportive measures, clonidine, trazodone,
yeah,
everything. Um, and then if I can get them to come back in, I would do everything as far as like helping them get comfortable. And if they have access to methadone, I would probably just say like, let's get you a dose of methadone and get you figured out as far as getting
yeah.
you more comfortable.
Yeah.
Um,
Do you ever refer them to the hospital or do you find that I don't know if that I think it probably is
I
patient
haven't had
dependent,
to.
but
I haven't
yeah.
had to, but I mean, obviously, like but I've been in primary care and felt like I knew nothing. So
Yeah.
if I was in that setting and someone came into my office and precipitated withdrawal, I would do anything to ensure that they're more comfortable, and
Yeah.
I absolutely would refer them to the ER at that point.
Yeah.
Um, I don't necessarily recommend that for everyone. Let's literally
Totally.
try to avoid precipitated withdrawal. That's
Yes.
the
In the
number
first place.
one.
Yes.
Right.
Name of the
We want
game
to
for
keep
sure.
people out of the ER for
Yeah.
sure. But if it's to a point where you're like absolutely panicked and you're like, this person, because if you see true fentanyl withdrawal,
I have not.
oh my gosh, I would never wish it on
Yeah.
anyone,
Wow.
anyone at all. Like they are very sick if it's really bad. I mean, and they literally look like they're coming out of their skin. They're sweating through their clothes. They're just like can't be. It looks like the
Yeah.
worst flu you could ever imagine times probably 10. Like it's
Oh
just
my
it's
gosh.
bad. It's really bad. I've had so many women that have that have gone through childbirth that said I will deliver a child without any pain medication 10 times before I put myself through fentanyl, like withdrawal from
Oof.
fentanyl again. Um so yes, like if that happens, then yeah, I would probably, if you feel really uncomfortable, always higher level of care, you know.
Yeah. And I'd be
Um
curious, like, I'd love to talk to, I haven't worked in the ER, but I'd be curious to, maybe I can snag an ER provider at some point and ask them
yeah.
about how they approach it. Cause I think that's another thing in primary care. It's like, I really one of the things I love about talking with specialists like you, we don't always know what happens on the other end. And it's like, this is the thing we're supposed to do is like seek other care, but it's like
Right.
really nice to hear kind of like what happens from there. I guess I would love to transition into talking about so phase one is kind of like shared decision making, your assessment. What does induction look like? Knowing that there are actual like very clear protocols of how to do
Mhm.
that. And then like we have addressed the early phase, risk of precipitated withdrawal, risk of withdrawal, how to manage it. And then when it comes to ongoing assessment, you've kind of already touched on the fact that you're doing an assessment of how they're feeling, if they're having cravings, and your practice
Mhm.
is and because it sounds like there's controversy of like, do you go up on the dose or not to help with cravings? What does that ongoing management look like after they've started it? They're doing fine. What does that look like in terms of like how you said you see them monthly, but like what are the things you're asking about? What are you assessing? Things like that.
Um, no, that's actually a really great question. I recommend, so in terms of the guidelines, so for resources, I recommend ASAM and SAMHSA, as far
Okay.
as like helping people kind of navigate those things. Um, as far as like the patient sitting in front of you, every follow-up I ask, okay, so for the after induction, I see them weekly for 4 weeks, and then we kind of do like little baby steps. And then I do bi-weekly for 2 visits. So for 1 month, I see them every week. The next month, I see them every 2 weeks, and then monthly thereafter, as long as there's no other illicit substance use. If illicit substance use continues, as far as other substances, not opioids like methamphetamine, alcohol, all those things, we continue weekly until patient's more stable. Um, and then on every single visit, I walk in, obviously do the intro and then ask them, how are you doing? How are you feeling? In terms of meds, are you experiencing any withdrawal, any cravings, any relapse since last time I've seen you? And vast majority of patients will tell me, especially the ones that have been using fentanyl, if they're at 2 on that initial visit, they're like, I'm not comfortable. Like I'm okay. I'm not having a lot of physical symptoms, but I'm not sleeping well. I'm still having some body aches and I'm still having some breakthrough sweating. I typically try to like mess with the dosing where in terms of the guidelines initially whenever heroin was a thing, the guidelines really wanted you to take all of the Suboxone or buprenorphine in the morning. They're like, this has a long half-life, you should be able to take it once a day and it lasts all day and you don't have to worry about it anymore. Anecdotally, that doesn't really happen. Most patients like to split their tabs and take it like every 4 hours, every 6 hours. Um, and that's typically on the 2 a day dosing. I typically recommend one in the morning, one in the evening. And then for the individuals that are continuing to experience cravings, I call it white knuckling. They're like, I'm literally just like they're one bad day away from using ultimately.
Yeah.
And I'm like, okay, so what's your thoughts on going up on the dose? I mean, I have found anecdotally that it decreases opioid cravings, which could decrease your risk of relapse. But just know that this will increase your physical dependence on the medication. I mean, you will be physically dependent on this medication. Without the medication, you're going to have withdrawal. So you always have to ensure that they're making an informed decision to pursue a medication like this. Um, and they usually opt to go up. they don't want to feel
Yeah.
like this, you know, they
Yeah.
don't want to use. So
Yeah.
and on increase, you can increase by a quarter tab, you can increase by half a tab. I typically go up by half a tab because the tabs are so small, it's hard for them to cut it.
Yeah.
I That's one thing I wish these pharmaceutical companies would do. Score these tabs. If you
Yeah.
want us to prescribe at the lowest possible dose to keep people comfortable, make
Yeah.
the tabs easy to split.
Yeah.
Like
I hate
it's
that.
I know. Gosh, it's so frustrating.
The
It's little,
chlorthalidone, I don't know if you ever prescribed for chlorthalidone, but it's like the tiniest little pill, and you're like,
like
the starting dose is like 12 and a half. You're like, how do you,
my
how?
little 80-year-olds in primary care is like, "Do I have it? Is it there?" Like,
Totally.
um, but yes, so increasing and then I would typically do a week follow-up if I do any adjustments. Okay, come back next week. Let's talk.
Yeah.
Sooner if you're really struggling. And then always, always, always every visit. Do you have Narcan? Do you have fentanyl
Yeah.
test strips? Specifically for people that are using methamphetamine, I want them to
Mm.
test their supply
Oh, that's a
for
great
fentanyl.
point.
Because most of what we're seeing in Oklahoma is contaminated with fentanyl. Most designer benzodiazepines on the street are contaminated with fentanyl. Most cocaine is contaminated with fentanyl. Um, so no one's safe. No
Yeah.
illicit substance use is safe, really, you
Yeah.
know. And safe is very relative in quotation marks.
Yeah.
But as far as fentanyl goes, so I always recommend, no matter what you're using, to always use a fentanyl test strip. You know, as far as harm reduction goes. So that's increase until comfortable. And then as far as continued monitoring, once they're stable, like I said, I see them monthly. You could push it out further if you have a really busy practice, you know, once you feel comfortable. Um, there is a lot of argument from people in legislation, specifically down here, that say that, and even we get it from insurance companies, that we need a documented taper, like telling patients, okay, we're coming, you can take this medication for a year, but now it's time to come off. And
Oh, I
that's
was just
so,
going to ask, do you ever have people come off of it?
yeah. Um, yes, to answer the question, just like straight up, yes, I do. I have patients that are able to come off of it. Statistically, though, the rate of relapse within 1 year of coming off of MAT is anywhere from 80 to 90%. So,
Yikes.
and I always have, I mean, in terms of the abstinence programs, you know, like, and this is not me harping on AA at all, because I think it's a great platform for many individuals. It's not great for everyone, but there are some people that really find benefit from it. Um, the rate of opioid specific relapse is about 90%. So, um, you know, just like telling a teenager you can't have sex, you have to practice abstinence.
Yeah.
We all know it doesn't work,
Yeah.
you know? Like
Yeah.
we know.
Yeah. And then
So
I think also just really underscoring, because before we started recording, we were talking about bias. And I think there is a lot of bias still of like people not believe, like they're like humans get
this
to
is a
make choices, but
disease.
this is a
Like
disease. And
it
it's like not,
absolutely is.
it's
And
not
that's
just
that.
like, I feel like doing this today.
And
Yeah.
I'll be honest, I've gotten a little spiteful with my communication with insurance companies. You know,
Yeah.
I'm like, I will write back to them in this like templated letter of, this would be you forcing a taper on this patient would be like you forcing a diabetic patient to come off their insulin.
Yeah.
Be like, you get it for a year. We're going to
Yeah.
cover your blood sugar for 1 year, and
Yeah.
then you don't get it anymore, and you get DKA, you know, like,
Yeah.
that's not how this works, you know?
Yeah.
And in terms of tapering, I do bring it up occasionally. I don't do it every visit because I think it seems forceful to patients.
Yeah.
Initially, when I always mention it initially on the first interview with patients on the induction, I'm like, as far as tapering goes, I want you to know the progression and the goals. If you ever desire to come off of this medication, I always recommend you bring it up and we have the conversation. Statistically, I would not recommend even considering tapering until you've been on this medication for at least 12 months, because the people that have been most stable and have had the best outcomes were on it for at least a year before they came off. Um, so at least, yeah, so at least 1 year before having the conversation. And then what tapering looks like is very, very slow.
Yeah.
It's not I've had so many patients try to like, just, they want to be done with it. They don't want to tie to the medication anymore, you know, and I get it. Nobody wants an anchor.
Yeah.
So they'll cold turkey quit, and then they're in my office within a few days in complete crisis, you know.
Yeah.
Um, but as far as tapering goes, I say, you know, let's try. I always put the patient in the driver's seat, because that's what we should always do
Yep.
as a provider is I I've seen it done other ways, and that's where you have to have the conversation with the patient ultimately, like where providers will automatically say, okay, well, you're on 2 tabs a month, I'm going to go ahead and cut you to 1.5, and I'm going to send the script in, and you're going to take 1.5. And I'm like, hold on,
Yeah.
hold on, let's not do that, that's a little extreme. So
Yeah.
I always just tell the patient, I'm like, you know, I would like the goal to be that you reduce by a quarter tab if you're able to cut it that small. If not, try to do a half tab. I'm going to give you the same script. I'm not going to change anything about your prescription.
Yeah.
And then at the end of the month, bring your leftovers. If you have 4 quarter tabs left, even if that's one whole tablet, we'll just cut the script by one tablet.
Yeah.
And it takes so much fear out of the tapering process for them.
Oh, that's
Um,
wonderful.
it seems to it seems to work a lot better. And then I have patients that will stay at that same dose for 3 months before they're interested in tapering more. And if we're decreasing by one tab every 3 months, I'm fine with it. Like,
I
it's
love
okay.
that. I love you sharing that perspective because I think yeah, I guess it's just like a personal share. Like I take Adderall for ADHD.
Yeah.
And so and there's so and it's because it's a controlled substance.
Yeah.
There's like it's not even in the same realm at all, but just like having a substance that has these like rules around it, it's or
Hmm.
this medication, it's like I feel the anxiety of like
Yeah.
you being like of them like don't take away the medicine because it's like it's
Like,
so hard to get in the first place.
yeah, but that makes Liz, that makes you such an empathetic provider, and just sitting across from the patient and having that share and telling them like, I'm human, just like you,
Yeah.
like,
Yeah.
I always tell them I'm not going to take your medicine away.
Yeah.
Like there are rules, there's laws I have to follow, but my top priority is to ensure you have medication. I have seen on the opposite end of this what it looks like, and I don't ever want to put you in that position. And you'll find this patient population like it's like they take a deep breath when you have that conversation. They're like,
Like what a relief.
oh, because
Yeah.
they have so much trust issues with the man, with the
Yeah.
system, and they've been
Absolutely.
stigmatized for so long. It's so sad. And I have one patient, he he was actually in some form of law enforcement that specialized in drug treatment or in drug law enforcement, and he did the injury thing, had a back injury, got
Yeah.
started on pain pills and went down the whole rabbit hole, was on heroin, the whole deal. And he sits across from me on our first visit and he's like, if you would have told me 10 years ago that I'd be sitting in this office, like I would have told you he just blatantly said, I would told you that you're an effing idiot. Like I would never be that person. And I,
Yeah.
and I looked at him and I was like, it's humbling, isn't it? And
Yeah.
he's like, so humbling. And that's what I tell patients. I'm like, you
Yeah.
realize I could be sitting on that table. Like
Yep.
I could be in your
Yeah.
position tomorrow.
Yeah.
So I do not judge. And whenever they hear that and feel the authentic, communication with it, they're just great. And that's where the gratifying part comes from. Like on a daily basis, I know that what I'm doing is making a difference. And I think that's what I struggled with in primary care. Like,
Yeah.
obviously, I knew it made a difference, but it was the long haul, like you're prescribing a statin, you're prescribing
Yeah.
insulin, you're modifying risk. And you might and my collaborating physician, put the spotlight on this for me, and it just like blew my mind. He's like, but you don't get the dopamine hits every day of like isn't that
It's so
terrible?
true. No,
But
it's
he's
so
like
true.
it's just like,
There's no
oh,
start to finish. There's no, that's
yeah,
why I love procedures because it's like,
yeah,
I did
yeah.
that. I
Ooh,
did
that
that
felt
thing and it's
great.
done. Yeah.
Yes, yeah, that was so gratifying. But in primary care, it's like that. Like, you probably prevented 15 heart attacks this year. Will we
Yeah.
ever know? No. But
No.
I can honestly say, like, from week to week, I see somebody come in full blown homeless, has no hopes of having their children back, I mean, in the worst possible shape they could be. And the next week, we're working on getting them into sober living. We're helping them find employment. They're working on getting stable transportation. We're supplying bus passes. I mean, it's like so
I love
gratifying.
that. So many
It's so
chills. I
gratifying.
love that.
It's good. It's good work, man. And that's why, like, I know what primary care is like. I've done it.
Yeah.
So I'm like, get some of that gratification in
I
there. Start
know.
prescribing
I know.
buprenorphine.
Totally.
And they're quick visits for the most part. Like, especially when people are stable. It's like they're in and out. You see
Totally.
them so frequently. You're doing check-ins. It's actually a really easy thing to manage. And now, like I do it, I'm like, man, why wasn't my initial collaborating physician on board with
I
this? Because
know.
this would have actually like lightened
Yeah.
up his load a little bit.
Yeah.
Um,
Yeah. Yeah. It's like, but when I build in the procedures during the day, it's like, oh, I get a break. But
yes,
it's still hard work and it's just, it feels lighter. Yeah.
yes,
I
absolutely,
love that.
absolutely.
That's so beautiful. Well, thank you so much. I feel like I could talk to you forever and
I
maybe we'll do
know.
some more chats about other addiction medicine things. But are there any like kind of like last pearls that you want to share for people or I don't know. I don't feel like you have a social presence,
I
like a
don't. I'm
social media
so
presence.
lame.
No, you're
Oh
fine. You're
said.
totally fine. No, I just offer that to people who have like
Yeah.
some sort of a company thing. But is there any sort of like you already mentioned some resources, which I'll drop in the show notes as well. But like any other kind of like parting words of wisdom to share?
Yes. One thing, Curbsiders podcast.
I love them.
They
I
have an
love
addiction
them.
medicine series. They have 2 seasons, and it's wonderful. I mean, it's a really, really, really good resource.
I love that.
And you actually get CME, and I forget
I
how it
love
works,
that.
but you know, listen to the podcast, and then you log into they always mention it during the podcast,
Totally.
obviously. They give you the link, and you log in and you get CME, and those CME actually count towards DEA requirements for if that's a requirement in your state. So,
Love that.
and it's
What an
and
easy way to start.
yes, and it's great, and they cover everything, substance use disorder. They talk about the social aspects, they talk about legal ramifications, all the issues. So it's great. It's a
I
really good
love that.
resource.
Well, thank you so much. This has been so
Yes,
fun. You're
good.
awesome.
I appreciate that so much. You're awesome.